Good afternoon. This afternoon, this will be the outline of our lecture. So we know that dengue in the Philippines has a seasonality and is affected by the environment. Its cases occur year-round, but cases peak during the rainy season. And high rainfall, as well as flooding and unsuitable storage of water, are linked with increased incidence of the disease. So the etiologic agent is the dengue virus. It has four serotypes, dengue 1, 2, 3, and 4, and all can cause the full spectrum of the disease. And humans can have four infections in a lifetime. Transmission primarily is via Aedes aegypti and can also be via Aedes albopictus. Aedes aegypti is a very efficient vector because it prefers to feed in humans and it thrives in close proximity to humans. Aedes aegypti is considered to be the primary vector and Aedes albopictus is the secondary vector. Both of these have limited flight range. Therefore, the spread of the virus primarily is mainly via mobile viremic humans. So the transmission of dengue could be seen as follows. First, a febrile viremic boy with a dengue virus infection is bitten by a mosquito. And then the dengue virus incubates for 8 to 12 days inside the mosquito. Then this dengue infected mosquito can bite another person and then transmit the dengue virus to her. And then after 3 to 14 days of the incubation period within the patient, the patient can now be viremic because she can pass the dengue virus to another mosquito if she is bitten during this time that she is viremic or febrile. So other modes of transmission could be blood-borne transmission or via mother to fetus, but these are rare occurrences. So what is the clinical and the laboratory diagnosis of dengue? So we know that dengue has an incubation period of 3 to 14 days and there is a sudden onset of high fever with three phases, the febrile phase, the critical phase, and the recovery phase. During the febrile phase, the patients typically develop a high-grade fever suddenly. This phase lasts for 2 to 7 days and is often accompanied by facial flushing, skin erythema, generalized body ache, myalgia, arthralgia, and headache. And some patients can have sore throat and injected pharynx and conjunctival injection. Anorexia, nausea, and vomiting are also common, and we should monitor the effervescence and appearance of the warning signs to recognize the start of the critical phase, which follows the febrile phase. So the laboratory findings in the febrile phase are the following: a CBC with a decrease in the WBC and mild to moderate decrease in platelet, and elevated liver enzymes, and hyponatremia. Let's talk about the tourniquet test. So the tourniquet test is now part of the new WHO case definition for dengue. It is a marker of capillary fragility and it can be used as a triage tool. And even if a tourniquet test was previously done, it should be repeated if it was previously negative or if there's no bleeding manifestation. So how do we do our tourniquet test? We take the patient's blood pressure and record it, and then inflate the cuff midway between the SBP and the DB and the diastolic blood pressure, and maintain it at that pressure for 5 minutes. And then reduce the cuff and wait for 2 minutes for the PTK to appear below the antecubital fossa. So a positive test is 10 or more PTK per 1 square inch. So the 30K test, however, has variable sensitivity and specificity, and using a cutoff of greater than 20 per square inch increases the specificity but loses the sensitivity. And we should note that the 30K test is more likely to be positive near the time of effervescence, and it is less likely to be positive in patients with shock. So again, in the febrile phase, the laboratory findings are as follows. There could be decreasing trend of platelet and WBC, and this is also the time that the virus can be detected via PCR or via the NS1 antigen test. So what are the clinical problems during the febrile phase? There could be dehydration, hyponatremia, there could be febrile seizures, and neurologic disturbances. Now let's go to the critical phase. So around the time of the effervescence, when the fever disappears, which usually is on the third to seventh day of illness, there is an increase in the capillary permeability in parallel with the increasing hematocrit levels. So this begins the critical phase, which follows the febrile phase. So this is a period of clinically significant plasma leakage, which may last for 24 to 48 hours only. This is also the reason why we give our fluids only for 24 to 48 hours during the critical phase. And this is the time during the patient may develop severe disease and some may go into being critically ill. Some patients also may improve during this phase and do not develop severe disease. A rapid decrease in the platelet count is associated with a rise in the hematocrit, and this is the time that we should watch out for the presence of warning signs. So what are the clinical manifestations? These are the following, and the laboratory findings are as follows. As we have mentioned, there is increase in hematocrit, moderate to severe decrease in platelet leukopenia. Again, decreasing hematocrit, and then during the time of near the time that the critical phase ends, the WBC increases followed by the platelet. So what are the clinical problems in the critical phase? There could be hypovolemic shock due to plasma leakage, and there could be end organ impairment from the prolonged shock, and there could also be severe hemorrhage. So the recovery phase follows the critical phase. This is the time where there is a gradual reabsorption of the extravascular compartment fluid, usually for 48 to 72 hours. This is the time where the classic Herman's rash appears. There is general improvement in the patient, and the GIT symptoms disappear, and the hemodynamic status stabilizes, and the diuresis improves. There could also be a note of generalized pruritus, bradycardia, and ECG changes. Again, the hematocrit starts to stabilize, the WBC starts to rise, and this is followed by the increase in platelet count. The clinical problems that can be encountered during the recovery phase are hypervolemia due to excessive fluid therapy, which can be also manifested as acute pulmonary edema. There can also be organ impairment due to prolonged or refractory shock secondary to ischemic hepatitis and hepatic encephalopathy, and some could have nosocomial infections. So, what is the laboratory diagnosis of dengue? So, actually, the acute management of dengue should be based on the clinical assessment and presumptive clinical diagnosis of dengue. So, a clinical diagnosis is enough for you to start management. The objective of diagnostic testing for dengue is to confirm a clinical diagnosis. Also, it can assist clinicians in learning to differentiate dengue from other febrile illnesses. It will inform patients that they have dengue so that they will know what to do, and also helps in surveillance. So, excuse me. So, viral isolation or viral culture and RT-PCR are considered to be the gold standards of dengue diagnosis. But of course, these are only done in RITM and it's not available bedside or in the outpatient setting. What we usually have is the NS1 antigen. A positive NS1 test confirms a dengue infection. It is easy to perform. It can detect both primary and secondary dengue infection. It's actually less expensive than these two other tests. It has good sensitivity and specificity, but not as sensitive as virus isolation or RT-PCR. IgM or IgG seroconversion could be also done, but this is also not easy to do because it requires acute and convalescent samples, so you have to use paired sera. What we usually do is a single detection of IgM. This identifies the probable dengue cases and is useful for surveillance, for tracking outbreaks, and monitoring effectiveness of interventions. So let's go to a case. We have a 5-year-old male with an acute onset of fever for 2 days associated with postprandial vomiting, um, a loose tooth, and the patient consulted with the ER. The vital signs are as follows with a positive tourniquet test at the right weakness in the right upper quadrant. So how would you classify this case? This is dengue with warning signs. So what laboratory test do you request? At this time, you can request an NS1 antigen. So let's go to dengue and COVID-19 first because we're still in the middle of a pandemic. So during the COVID-19 pandemic, healthcare providers in areas where dengue is endemic need to consider dengue and COVID-19 in the diagnosis of acute febrile illnesses. So most people with dengue and COVID-19 have mild illness and can recover at home. However, some can have severe manifestations of the disease. The clinical management for people who develop severe illness with either of these two diseases is quite different. So it's important to distinguish them, and both of these severe manifestations require hospital-based care. Healthcare providers should perform the appropriate tests for dengue and for COVID-19 for patients with febrile illnesses. and follow the patient closely for warning signs. Complications for both dengue and COVID-19 can develop before test results come back, so clinical management should be guided by clinical presentation. We know that COVID-19 and dengue can have overlapping symptoms such as fever, fatigue, diarrhea, or cough. So, is it dengue or is it COVID-19? So, this is a suggested approach on who should be tested for COVID-19 and or dengue. If a patient has respiratory symptoms only, a COVID-19 test could be done. If a patient has fever and other signs suggestive of dengue NS1 antibody tests and COVID-19 tests should be done. If a patient has fever and respiratory symptoms, a dengue test and a COVID-19 test should be done. We should also note that dengue rapid diagnostic tests have shown low sensitivity, so the negative predictive value is very low and a negative test result would not rule out a case. And there are reports of a possible dengue false positive in COVID-19 cases. So what do we do if we have patients who present with possible dengue and or possible COVID-19? So we provide a standard of care for patients based on the admitting diagnosis while awaiting laboratory diagnostic results. The proper infection control prevention measures should be done, level 3 PPE for all suspect cases, and we admit these cases in isolation wards. And once a COVID-19 diagnosis is confirmed, we transfer them to a dedicated COVID ward. Since, of course, clustering of cases is common in both of these diseases, efforts must be made to strengthen surveillance so proper infection control could be done. Let's go back to dengue. So the management decisions in dengue include this spectrum of information. You should know what phase of the disease the patient is in, the presence of warning signs. We should know the hemodynamic status of the patient. We should know their laboratory tests, and we should know if there is overt or concealed hemorrhage. So depending on the clinical manifestations and other circumstances and your impression, patients can be classified as follows. They can be into group A, and these patients can be sent home. They can be into group B. These are the patients that need in-hospital management. And group C are patients that require emergency treatment and urgent referral. This is the continuum of the dengue illness. Um, this is the dengue case classification and levels of severity by WHO 2009, which is this is the one that we are using nowadays. Let's go through them one by one. So what is the case definition for dengue without warning signs? So what is a probable dengue case? A patient who lives in or travels in a dengue endemic area with fever with any two of the following: headache, body malaise, myalgia, arthralgia, retroorbital pain, anorexia, nausea, vomiting, diarrhea, flushed skin, rash, or a positive tourniquet test. And a laboratory test with at least a CBC which shows leukopenia, or with or without thrombocytopenia, and or a dengue NS1 antigen or a dengue IgM antibody test. A patient is a probable dengue case becomes a confirmed dengue case once there is viral isolation or PCR based on this DOH classification. So what is the definition for dengue with warning signs? The patient again lives in a dengue endemic area with fever plus any one of the following. Any one of the following. Abdominal pain, persistent vomiting, clinical signs of fluid accumulation, mucosal bleeding, lethargy, restlessness, liver enlargement, decreased or no urine output within 6 hours, and an increasing hematocrit or decreasing platelet count based on laboratory findings. And severe dengue is defined as follows: the presence of severe plasma leakage leading to shock or fluid accumulation with respiratory distress, severe bleeding, and severe organ impairment as defined by the following. So what is the stepwise approach to the management of dengue? First, there should be an overall assessment, the history, the physical examination, and investigations or laboratories specific for the patient. So what are the data that we need to ask in the history? The date in the onset of the illness, the quantity of the oral intake, if there is the presence of warning signs, if there are losses to diarrhea or vomiting, if there are changes in the mental state of the patient, the urine output of the patient, and other important relevant histories if there are similar cases in the neighborhood, for example. We should know also the hemodynamic status of the patient because hemodynamic assessment can be in a continuum, and we know that from a stable circulation, the patient can go first into compensated shock, and then if this is not addressed, they can become hypotensive. So we will go into these later, but suffice it to know that in compensated shock, there are already signs of poor perfusion in the periphery, but the BP is still maintained. And in hypotensive shock, there's already no or unrecordable BP, and there is presence of other end organ damage. So what is the definition of hypotension? So this is the definition of hypotension. You can compute for the normal value for age. And in adults, this is the definition of hypotension. So a complete blood count should be done at the first visit for dengue probable cases. So the hematocrit in the early febrile phase establishes the patient's baseline hematocrit. A decreasing WBC count makes dengue very likely. And if there is a rapid decrease in the platelet count with a rising hematocrit, this suggests that the patient is progressing to plasma leakage or into the critical phase. In the absence of the patient's baseline, you can use a age-specific hematocrit level to know if the patient's value is rising. So other additional tests, the tests that can be considered are the following. So the second step is diagnosis and assessment of the disease phase and disease severity. So based on the history, physical examination, and the CBC, the attending clinician should be able to determine if the patient indeed has dengue and in what phase of the disease the patient is in, if there are warning signs, what is the hydration and the hemodynamic status, and whether the patient requires admission based on these information. Also, disease notification is important because public health measures should be initiated once a dengue probable case is seen. Laboratory confirmation is not necessary before notification but should be obtained. So the third step is management. So what are the management decisions? So depending on what you have assessed the patient to be in, the clinician will decide whether the patient can be sent home, should be admitted, or should be resuscitated urgently. Let's now go to dengue without warning signs. So what is the management during the febrile phase and what are the do's and don'ts? Let's go again to another case. This is case 1A, a sibling of case 1, with an acute onset of fever for 2 days with no other complaints, with normal blood pressure, slightly tachycardic, slightly tachypnic, with slight fever, with dry lips, tourniquet test positive, clear breath sounds with no abdominal tenderness, and the extremities are warm. So how do you classify this case? This is dengue without warning signs. And what laboratory test do you request? Also an NS1. So the management of patients who may be sent home are the following. So who can be sent home? Patients who are able to tolerate adequate volumes of oral fluids and pass urine at least once every 6 hours. And patients who do not have any of the warning signs, any. So particularly when fever subsides and the patient enters the critical phase. So the patient should be reviewed for possible disease progression, including decreasing white blood cell, defervescence, and warning signs until they are out of the critical period. If the patient has stable hematocrit, the patient can be sent home and advised to return to the hospital immediately if there is any one warning sign. So, home instruction includes encouraging oral fluid intake of ORS, fruit juice, or other fluids containing electrolytes or sugar to replace losses from fever and vomiting and diarrhea. Adequate oral fluid intake may be able to reduce the number of hospitalizations. Fluids containing sugar or glucose may exacerbate hyperglycemia or diabetes, so they should be taken into consideration. Paracetamol will be given for high fever if the patient is uncomfortable. The interval of paracetamol dosing should not be less than 6 hours. It should be a maximum of 4 grams per day only. Tepid sponge bath may help if the patient still has high fever despite paracetamol, and aspirin, ibuprofen, or other NSAIDs are not indicated for febrile patients with dengue. So the caregiver should be instructed that the patient should be brought to the hospital immediately if any of the following occur. If there is no clinical improvement or if there's deterioration, especially around the time of defervescence. The following could be evaluated: the appearance of the patient, if there is lethargy or irritability or restlessness, if there is severe abdominal pain, if there is bleeding, if there are bleeding manifestations, if the patient now has cold and clammy extremities, which could mean that the patient is in shock, if the patient is not passing urine for more than 4 to 6 hours, or if there is persistent vomiting. So patients who are sent home should be monitored daily by their healthcare providers for the following information: the temperature pattern, we should watch out for the effervescence, we should watch out for the intake and the losses, the urine output, if any warning signs develop, if there are signs of plasma leakage or bleeding, and if there is changes in the hematocrit, white blood cell, and platelet counts, so that we will know if there are warning signs that develop, and then the patient could be admitted as appropriately. So, what is the fluid management in dengue without warning signs? So, oral rehydration solution should be used as follows based on the weight using the currently recommended ORS. This is the Ludan method. So, based on the patient's body weight, this is the amount of the ORS to be given. So our patient is 23 kilograms. So based on this, we give them around 50 to 60 ml per kilo per day. And this would be equivalent to around 1,200 ml per day. So we give a reduced osmolarity ORS containing sodium of 50 to 75 millimole per liter only. So soft drinks and sports drinks which are lower in sodium should not be given. So let's summarize what is the management of dengue without warning signs. Patients who do not have warning signs and who are able to tolerate adequate volumes of oral fluids and to have adequate urine output with a normal CBC and who are able to monitor daily their hematocrit. Treatment is for the following: advice only for adequate bed rest, adequate fluid intake, and proper dosing of paracetamol. And patients with stable hematocrit can be sent home. The monitoring should be as follows. There should be a daily review of the disease progression. If there is decreasing WBC, defervescence, or the appearance of warning signs, you should advise the caregivers for immediate return to the hospital if development of any warning sign is noted, and a written advice for management or a home care card for dengue should be given to the patient as guide. So this is a the WHO suggested home care guide for home care card for dengue. So this instructs the patient on what should be done, on what should be avoided, and what are the warning signs that should be watched out for, as well as the laboratory results that are done daily, and so that you could know if there is a problem in the hematocrit. Lastly, this is the flyer that I gave to my patients during the 2019 outbreak. This just shows what should be done at home and what are the important warning signs to watch out for in the patient and what are the preventive measures for dengue in their household. Thank you.